Great. Thanks, Dr. I'm excited about very innovative approaches to bifurcation PCI as part of this webinar. I'm delighted to introduce Dr. Carlos Collet from ULST. He is very well known for his groundbreaking work with coronary CT guided PCI. And today we're looking forward to your case-based discussion and talk on bifurcation PCI involving coronary CT in the context of the P4 study. Over to you, Carlos.
Excellent. Thank you very much. I think just to double check that you're hearing me well and you see my full screen.
Yes, we are. All
Excellent.
good.
So I think that, the more that we learn about CT and the interaction that it has with the assessment of bifurcations, the more I believe that in the future, for every complex bifurcation planning, CT will become a very important tool, an essential tool to understand not only the bifurcation itself and all the geometrical information that we know from the past matters, but also the distribution of the plaque. This is a key element for predicting, for example, the risk of a side branch occlusion, for understanding whether are we doing the multi-layer stenting, for example, in the DK crush, where that is at the level of the calcium, away from the calcium. So there's a number of things that you will see after this presentation, and I just want to provoke your thoughts to see the potential of CT in the way that I'm going to show it today for bifurcation planning. Okay, these are my disclosures, and then again, Tanvir asked me to basically do it around a case, and I think this is very appropriate. And what I'm going to do now is basically, this is a typical case in our lab. 70-year-old male, in this case, CCS class 2, under medical therapy, normal renal and ventricular function. And it comes to the lab, basically, let's say the classical routine, the patient lies on the table, you do a couple of shots, and this is what you get. So you're at the table, basically you see lung disease in the LAD. I'm going to stop these two pictures just to give you kind of more time to understand the disease. And there's a number of questions, of course. And then you are saying, okay, looks LAD, there is something, the distal left main. I'm not sure how significant this is. Looks long, looks significant. In the right side, you see the caudal. It looks like there is a trifurcation, a high marginal. So yeah, it doesn't appear to be so simple in terms of the approach. So basically we need to take a decision, and that's basically the way we actually work. And you can have imaging or physiology, but at the end of the day it boils down to a treatment strategy. And in this case you can say, well, the disease looks fairly restricted to the LAD. We can perhaps do a LAD PCI. Some people might say, oh, spare the left main because it's trifurcation. Well, that's a consideration to have. Some people will say, no, listen, there is some disease at the level of the circumflex. It's better maybe to go up front with two stents. And some colleague will come around and say, listen, it's a trifurcation, very good distal beds. This is a very nice case for surgery. And then you might say, okay, that's a consideration as well. And then you might say, okay, but if you look at the trials, some people will say, well, basically you can manage this patient medically. So a number of options on the table. And basically, if you're an interventional cardiologist and you're at the table, this is what is happening in your brain. You're trying to think, well, should I cover that plaque? How should I modify that plaque? From where to where should I stand? Which vessel, which size is that vessel? How can I assess the side branch? If I'm going to modify the calcium, which is the best tool to modify this calcium? And basically, we have around 30, maybe 60 seconds in this type of ad hoc PCI to take a decision about the coronaries of that patient. And well, if you start taking decisions without the correct amount of relevant information, this is what is going to happen. If you put this patient under the hands of 3, 4, 5 different colleagues, everybody will do something different. And when everybody's doing something different, basically, this is what happens. This is data, landmark data from Professor Soroy's Syntax 1 trial, basically showing the variability in the distribution of the outcomes, which is basically a direct consequence of the variability in treatment or decision making. So basically you see here, for example, every little sphere here is basically one hospital, one side. And you see here that there were sites that were very, very high rate of MACE with surgery and very almost zero rate with PCI and vice versa. So really, this is one of the biggest problems that we have today in interventional cardiology, is the variability in treatment. And no wonder why. The reason of this variability is basically we're taking most of the decisions based only on an angiogram. And we know that when we look at an angiogram, we basically have no real understanding of the plaque characteristics. We don't understand the disease burden. You cannot assess vessel remodeling. And if you think about the physiological component, well, you can guess whether that lesion is producing the ischemia or maybe something else. We have demonstrated that you cannot assess the pattern of disease looking at anatomy alone, so you need physiology for that, and you have absolutely no clue about the status of the microcirculation in that given patient. So of course, there are solutions for that, and we all are familiar with the fact that we can, of course, use invasive physiology or physiology in general, but we also need to realize that the penetration of the adoption of this is quite low. Even we have Beamer in the call. The Netherlands is one of the highest countries in Europe for physiology adoption. They have like 28-30% of the PCIs they're using physiology, but even in the highest countries of uptake, remains relatively low. On the other hand, we have the use of intravascular imaging that, of course, will inform about the plaque characteristics. But again, this is limited by the penetration. And although we have seen spectacular double-digit numbers in terms of growth of intravascular imaging the last couple of years, this remains to be very, very low when you account for the total number of PCI. So the question is, how can CT help? And there are a number of ways that CT can help you. And of course, everything starts with the first slide, which was basically what are the patient characteristics, where is the clinical scenario, and what is the angiographic picture. But again, CT can also shed light on what are the plaque characteristics of the lesion that we're targeting to treat, and of course, what is the physiological component. And this brings us back to the patient. Again, I showed the angiograms again, and I'm going to explain how CT will add information that will again help us take the decision on the doors that I showed before. And let's start by assessing the plaque. When we assess the plaque by CT, we have developed this framework of understanding of education. This is basically the only 4 names that an interventional cardiologist needs to remember in terms of using CT for PCI planning. On the left side, you see the 3D MIP, which is basically a gross understanding of the anatomy with an emphasis on the calcium burden. Then we have the axials, which are basically used to select which type of guiding is best to have enough support to do intervention in that particular vessel. Then we have the MPRs that inform us about the severity of the lesion, the length of the lesion, and also the plaque distribution, and the cross-sectional view, which in my view is one of the most important reconstructions because it's very similar to IVUS and OCT. And basically you can understand what is the arc of calcium, what is the plaque burden, etc. I'm going to show, of course, examples in the case that we are talking about. So let's go back to the case. Now we're pulling of the previous slide, basically the MPR. And the MPR we see here, the first thing that I see when I look at these MPRs is the fact that this is not an LAD disease. This is a left main disease. The plaque extends towards the mid portion of the left main. And when you look at this piece of calcium here, you see that if we're going to treat this lesion percutaneously, the stent has to be extended to at least the mid part or the proximal part of that left main to cover the complete disease. Now, when we measure this distance, and we can do that in any of the commercially available softwares, and we are trying here to understand what would be a healthy landing zone, the same as we do, for example, with intravascular imaging. We measure from, let's say, this mid portion of the left main, and then we go until the mid LAD. That appears to be very, very normal, and this gives us a length of 48 millimeters, which is perfect because we have a stent of 48 millimeters. So theoretically, this could be covered completely from normal to normal with one stent. I want to make here a short comment, and is the fact that CT has a negative predicted value for disease of around 98-99%. So one of the things that I teach my fellows when they're learning CT is that if you see a normal cross-section by CT, 90% or 80% of the times will be normal, and 100% of the times will have certainly an adequate landing zone with a plaque burden less than 30-40%. So that's an important detail to keep in mind. Now, the beauty of CT is that we are looking at the pictures, of course, in the three-dimensional space, but you can go in any branch. So in this particular case, we're talking about a left main trifurcation. So of course, it's relevant to understand how is the distribution of disease in the circumflex. You see the circumflex here in the middle. And although you see some disease in the proximal circumflex, this is very, very little amount of disease. So basically the risk of this branch or to have a problem at the option is very, very low. Then we look at the ramus, and the ramus again, there is no disease at the level of the ostium of the ramus. There is some disease in the proximal part of the ramus, but again, favorable for example, a provisional strategy. Now, what has really changed, and I think Yanis will explore this in depth in the second part of this webinar, is the fact that we're not looking anymore at these pictures in this grayscale as the radiologists or the imagers used to do. We're basically now taking these pictures and creating three-dimensional meshes of the disease. So of course, we have the lumen, and then we just plot in 3 dimensions the plaque on top of it. What you see on the right hand of the slide is basically calcium. The white spots are calcium, and you see again the rest is basically the vessels and the non-calcified plaque. So if we go to the case that we have on the table, basically we're looking at the fact that again the calcium extends to the left main. The circumflex basically takes off an angulation of about 90 degrees. And there's this ramus, which again is large. And you see here the distribution of calcium in the proximal part of that ramus. So this is an unprecedented assessment. And I think that is extremely intuitive. You don't need to be an expert in CT to understand what you're looking at. And I believe that any interventional cardiologist without any training in CT will quickly understand what are the characteristics of this particular disease. Now, what we're doing in the trial, because this is, I have to say, we're almost finishing the P4 trial, is that we are putting these geometries, these reconstructions inside the lab. And these pictures, these geometries are synchronized with the C-arm. So every time that you move the C-arm, you will know exactly what you're going to see in the angiography without putting your foot on the pedal. And that, of course, you can imagine the consequence of that. You'll basically be reducing directly radiation and contrast. But the most powerful part of this is that you can see the plaque in the 3-dimensional space in the 3 vessels during the procedure. And that adds a layer of information that is very, very powerful, especially when you have complex disease with a lot of calcification. And there are a number of studies already showing the accuracy of the CT when you're trying to look at either plaque volume, plaque burden, or even calcification arc. I just show you a picture. I will not show you data. I just show you a picture that basically shows how you can basically with CT understand what is the calcification arc, what is the plaque burden. You see here, for example, in the cross section, the fourth from left to right, that you see this allo. This is basically a fibrotic plaque, again identified by IBUS and in this case VH. And again, identifying plaque composition by CT is quite straightforward. We have basically the same components, and the key, in my view, element that facilitates the understanding of plaque by CT is the fact that the intensities of the plaque can be measured for free in any screen basically. And if you have Hounsfield units below, let's say 50, this is most likely to be lipidic. The Hounsfield units are between 50 and 180. This is what we call fibrotic tissue by either pathology or VH. And if you have high intensities, typically above 300 or 400, these are calcified lesions, which are very easily to identify also visually. Now, this, in my view, the way that CT actually helps looking at calcium is basically solving one of the biggest needs that we have in the field. And this, of course, apply to the field of bifurcation. And the reason is because we are not good at looking at calcium with angiography alone. This is a landmark work from Gary Mintz, basically showing that around a third of vessels with severe calcifications more than 180 are invisible in angiography. And why this is important? Well, the major predictor of external expansion is basically calcium. If the calcium is not well prepared, this would likely lead to external expansion, again, shown again by Gary in a similar work. But what is really important is the fact that when we treat patients with severe calcification, this basically is associated with a 3 times or 30% or increase in mortality compared to those patients treated with PCI without calcification. Now, if we go to the case, now we look at basically the distribution of the calcium, and we see again that the calcium at the level of the left main is a 90-degree calcification, so this is not really a severe calcification. And then you see the other pieces of calcium basically in the proximal part of the LAD, some on top of the we'll call this the polygon of confluence or the trifurcation, and then some proximal calcium in the LAD. But again, not really severe calcification requiring an advanced plaque preparation. And CT, in my view, will become one of the most important tools to assess calcium. I would explain why. But basically, you can characterize calcium morphologically, the same as you do with IVUS or OCT. You can understand calcium in the three-dimensional space, with that makes assessment of calcium very, very intuitive. And you can assess how hard the calcium is, which is something that is specific for CT, and that is basically due to the fact that you can assess the calcium density. And I will not talk today about wire bias. This is something that we're working as well, basically trying to identify which are the cases that rod ablation might be the best treatment strategy. Now, how can we do that? Well, very easy. You have here the assessment of basically of the circumference of calcium. And here you see that IVUS and OCT on the left side, and you see how it looks in the cross-sectional view with CT. So again, quite easy to identify the circumferential calcification, semi-circumferential calcification. The same applies for thickness. You see here on the top, a thin calcification, in the bottom, a thick calcification. And here you can also measure, of course, the length of calcification. Now, by far the most novel aspect of all this characterization is the fact that you can derive what I call the degree of compactness of the calcium, or how hard the calcium is, as I mentioned before. Now, I'll bring your attention to cross-section F, G, H, I, and perhaps J. And if you look at these cross-sections, you will tell me, well, this is basically circumferential calcification. And that is true. If you look this by IVUS, it will be just a shadow around it, and OCT will be the same. But when you measure the density of this calcium in their respective quadrants, so every 90 degrees in this case, you see, for example, that cross-section G, there is hard calcium at 3, at 6, but the calcium on here on this quadrant, on the superior quadrant, is basically less hard. I don't want to call it soft, but less hard. And then you see more or less the same here applying. And so using the certification of density, you can basically understand, we have understood already that most of this circumferential ring of calciums is not homogeneous calcification. This is just basically, it depends, of course, of the patient, depends on, in my view, on the age of the calcification, but you'll see here that this is most likely to be heterogeneous. Now, imagine that you have this three-dimensional map. You can, of course, plot that on top of your angiogram, and you can understand where the calcium is located. And again, you will see we have spectacular cases where we have seen that this concept of density basically plays a big role in understanding where would be, or what would be, the likelihood of extended expansion. You see here a case of the bifurcation with this diagonal, where you have the distribution of the calcium basically away from the bifurcation, or in the other part of the bifurcation. The Hounsfield unit were extremely high. We deliver in this 120 pulses of IVL there, and even after that, we could not expand the stem properly. Now, let's continue to the case, because we have to take a decision based on basically on how to treat this gentleman. And the other piece of information that CT can add is basically telling us how big is that vessel, not in terms of the length or the diameter, but basically on the mass that that vessel subtend, which is basically uh, essential information to decide even on technique. And we see here immediately that the LAD basically subtends here about 25% of the mass, but look at the ramus. The ramus is as important as the LAD in this case in terms of the mass that it subtends. And then you have here the circumflex, which is a very small circ with about 10% of the left ventricular mass. Now, we have a complete analysis from the morphological point of view with the plaque, with the calcium, and on top of that, we can also add physiology. And how physiology can help in this case? Well, the classical use of physiology is basically to understand where the lesion is flow limiting or not. This is what is written in the guidelines today. And that has led in trials, for example, like FAME2 and FAME1, to reduction in the complexity on the number of stents that you need to place. But I think that the field of physiology has been completely revolutionized by the fact that by extracting the pattern of disease from that particular vessel, you can predict the outcome of PCI. And this is completely new. So I think that physiology now is becoming more relevant than ever before, because we're not using that anymore in the classical way. We have kind of moved to understand that physiology is more than just positive or negative story to actually help us in the lab how to perform the best procedure to get the highest degree of functional revascularization. And when it comes to CT, of course, we have this technology called FFRCT. And again, you can use this technology as kind of, again,
We lose Carlos just a bit.
Yeah, looks like we did. Let's give him 1 second, see if it comes back on. Dr. Rab, I would recommend, yeah, there we go. He's probably coming back on. That's what I'd recommend. Just 1 moment.
It was a great talk so far. I just
That slide deck is amazing, isn't it?
Very interesting. I
Just
think
in the
it's
meantime, while
particularly
we're waiting
relevant.
the one thing that pops in my mind is kind of while we're waiting is, I mean, when you see images like this and the discussion that it generates, I mean, the patient was sounds like an elective outpatient cath. Would anybody think based off this, you should just start with CT rather than taking these people to the cath lab?
I think a lot of people get CTAs now, don't they? I mean, and I think that we could just magnify all that, particularly when we have a photon counted CT come along, we can make it part of this one whole process, right? I mean, a lot of people are getting screened, particularly elective ones, and an outpatient with coronary CTA. Unfortunately, the insurance companies are our major limitation here. Is they're really hard to get it through, and it should be the first test, not a nuclear spec test or something like that. It really should be the first test if you think there's a high probability of coronary disease, unless somebody's really unstable. Or ACS is a different beast altogether.
Amazing though, you can basically walk through the MLD max algorithm before you ever walk into the lab based off what he's showing.
What do you think, Nick?
Yeah, I think you're right, Dr. Rab. So in terms of a lot of outpatients go through the CTA, and there's higher uptake in US as well. Europe has been doing CT for much longer, and I think with having CT FFR, so you're not only getting anatomy, you're also getting physiology at the same time in an outpatient setting, just by seeing the patient in the office, and you can use that raw data information to further plan for a PCI. And so when you do the heart cath, you actually know what you expect in terms of even planning for a PCI up front.
I would agree, and I think
Go ahead.
particularly relevant. Oh, he's back. Yeah, brilliant.
Sorry, we lost you there for a minute. Okay.
Sorry. And you know where was my last slide?
Probably physiology. We're doing the physiology part.
Your slides were
Okay,
too
very
good. It's making us feel bad, so something had to happen.
We're talking about integrating physiology. So start off physiology. Yeah, go to physiology. Yeah. Okay.
This is what happened when you do a live webinar. Huh? This is a part of the game. So I was saying that in addition to all the anatomical information, you can of course get the physiological part. And when you think about physiology, of course, we have to consider physiology in the traditional use of physiology, which basically has been defined by all the FAME trials and is in the guidelines, which basically is to detect if the lesion is flow limiting or not. But the reality is that today we're not using physiology anymore in that way. Of course, we use physiology to understand if the moderate lesion is significant or not, but the big change in the use of physiology is the fact that by looking at the pattern of the pressure drop or the distribution of resistance at the level of the epicardial vessel, we can predict what is going to happen in the after PCI. And this is a new way of using physiology. In my opinion, is more clinically relevant than before, because now we're adding a guidance component with the use of physiology. And when it comes to CT, it's basically you can do many things, and I will show you basically what you can do. Of course, on the left side, the classical use, guidelines, positive, negative, but in the middle, we have this ability to understand again in every single point of the coronary tree how the pressure is being lost. And this makes this changes the procedure many times in the way that PCI is basically the mechanism of action of PCI. You require to have a resistance that you need to basically reduce or eliminate. If you don't have a resistance from the physiological standpoint, basically PCI, yeah, it's not indicated. So if you do this pullback curve and it's completely diffuse, well, basically the PCI will not be addressing any pressure drop. And that's an important concept that needs to be kind of discussed. And basically with this technology, I think that we have evolved to a place where we have something called the FFRCT planner that we can basically do virtual PCI. I will show all of this in the context of the case. And I just want to kind of emphasize here the fact that you can derive these virtual pullback curves in the same way that you can do an FFR pullback or an IFR pullback. And then you basically understand that the case on the right is a perfect case for PCI. The case on the left is a very, very bad case for PCI, because what we also understood recently is that we cannot increase flow with PCI in diffuse disease, but that's for another time. Now, if we go back to the case, this is what we see. This disease that looks long in the LAD from the left main is basically focal disease. All the pressure losses are located in that very, very ostial LAD. If you do a pullback curve, this is how it looks with a very high PPG, 0.62. Again, all the pressure losses located at that particular place at the ostium. And again, imagine that for every single case that are coming to the lab, the CT analysis will provide you with basically a complete map of the anatomy, including the plaque in 3 dimensions in the 3 vessels. And I'm talking about the plaque in of course, the volume of the plaque, but also the composition of the plaque. And on the right side, a complete map of the physiological situation from, of course, the flow limiting decision, yes or no, but also the location of pressure drops. And again, you can mimic the PCI in this case. Okay, what would happen if I put a 48 coming from the left main to the mid LAD? Well, basically you will be increasing the flow and putting that patient above the ischemic threshold, 0.82 in the distal part of the LAD, and that basically will certainly make the patient feel better. Now, what was a very complex and difficult decision-making process now becomes an extremely simple procedure. Now it became 7 French, radial, 3 wires, a 48, and what could have been a very complicated long procedure from both the strategy part and the technical part becomes a straightforward procedure with a provisional from the left main to the mid LAD, landing on normal landing zones, POT, post-PCI FFR 0.88, and that's it. So everything that you have seen in this case, basically I took this case from before, is what we are basically doing in the trial. We're basically randomizing patients to CT or IVUS to be treated following that with that guidance. And in the CT arm, we're basically doing everything that you see on the screen. Complete understanding of the anatomy before you go in the lab, a specific patient-specific guiding, so you don't have to change the guidance anymore because you choose the one that basically is most fitted for that particular anatomy. You understand the severity of the calcification, understanding right away whether advanced plaque modification needs to be done. The mass at risk, which in my view is crucial in bifurcation lesions where you're trying to define the best technique. And of course, also in the lab, assessing the best view. And the best view, again, is important because you need to find a view that is good to see the ostium of the sour branch, or to see other characteristics of the bifurcation. I think having that information in the lab really helps. And the whole physiological part, which is basically, again, understanding the pattern of disease and the significance of the lesions, and also predicting what would happen if I do this or that technique. I'm very happy to say that we have included 952 patients as of yesterday. It was the last time I looked at the numbers. We think that we're going to be finished before EuroPCR, which comes in a couple of months. We'll see. But basically what we're doing is we're randomizing again a little bit more than 1,000 patients with CT, with everything that you have seen in the last few slides. And again, the control group is IVUS guided PCI with a non-inferiority design with MACE as an aim at 1 year. So to conclude, and we have a few minutes still to have a good discussion, I think that CT has evolved in a way that is able to characterize CAD both morphologically and functionally. It's not anymore a rule out tool. This has really evolved, and I didn't show any of the new CT scanners, but that is just mind-blowing to see how the hardware is evolving. The second point is that we're testing all this in P4, where we're basically integrating CT for two things. It's important to kind of dissect what we're getting from the CT. The first one is the planning part. So going in the lab, knowing exactly what you're going to find with a clear map of where the calcium is, where the problems can be, where the bifurcation, basically what is the characteristic of the bifurcation actually before you do the first injection. And that changes the way you approach the case. And the second element of the P4 is the guidance, the online guidance, basically having the plaque or the map of plaque in front of you during the procedure. That really helps. And we believe, firmly believe that if this approach shows to be beneficial, I think this is going to become the way they will be doing procedures in the future. Thank you very much for the invitation and for your attention. I'm happy to address any remaining questions.
Fantastic. Thank you so much. That was so informative. Dr. Webb, if I might ask a question, and I agree, I think having the information, particularly the mass at risk in identifying a side branch that is important enough is so crucial in terms of planning. As part of your P4 trial, Carlos, do you allow the use of IVUS peri-procedurally for anything, particularly, I mean, in bifurcation stenting? It helps, intravascular imaging is helpful for rewiring, and particularly when you find points like that where it might be difficult. Is IVUS allowed within the protocol?
No. So if your patient is randomized to the CT arm, basically if you do IVUS, it's a protocol violation. When we started the trial, we thought that, we were really, we knew that all these trials looking at intravascular imaging will be positive based on historical data. So we said, listen, we're really testing whether this can have the same outcomes as IVUS. So we sampled, when we did the sample size calculation, we did an assumption that we said, well, at least 10% of the cases the colleagues will use an IVUS because, sometimes you really want to check. That number today is 2%. So we don't have a lot of people looking for the IVUS, and the reasons are two. From the let's say, imaging part, so the IVUS before implanting the stent, I think CT offers comparable and sometimes better information than intravascular imaging and easier to interpret. The post-PCI part, where we mandate in the trial is to use device detection. So you have to use a stent boost, a clear stent, whatever you have in your lab, 3D stent, doesn't matter, to be sure that you are not leaving any under expansion behind, okay? And we're also, is mandated by protocol in bifurcation lesions to do this, to be sure that, and again, you have a very well extended expansion at the level of the bifurcation.
Thanks very much.
Carlos, if I could ask you a question too. We've been using a lot of CT as well in the Netherlands, and I agree with you that it's an amazing technology because it allows you to have the complete three-dimensional anatomical information, not just the luminogram, which we get with the coronary angiography, but actually information about the plaque itself. In my experience, and you already mentioned this, the negative predictive value is extremely high, but the positive predictive value can be a little bit disappointing at times when there can be a lot of disease on the CT, but you take the patient to the lab and it's still relatively moderate. So I guess my question is, there's two parts to the question. Do you think that there's ways that we can standardize the CCTA with particular settings for the CT scanner in terms of KV that more standardize the Hounsfield units that we get out on the other end to optimize the standard CTs that we have? And do you think that the higher resolution that photon counting CT will offer in the near future will change the game even more?
Yeah, so Bimer, thank you. There are two super relevant questions there. So the first one is that we, one of the reasons that I like to do clinical trials is because you always learn something that makes you practice in a better way. And one of the big things that we learned from P4 very early on was the fact that the way that we were doing the scans, we were doing rule-out scans. And if you do rule-out scans, you cannot see what I showed you in the pictures before. These are cases where basically if you have calcium, you have to increase the energy of the tube. You have to increase your kilovolts because otherwise you're going to get a lot of blooming. And these are the typical cases, Bimer, you're saying, they put in the report we cannot determine the lesion significant or it's very significant. Then you do an angio and you see nothing. That the reason of that problem is because from the radiology side, the radiologists have been trained with this concept called ALARA, which means basically as low as reasonably possible radiation, which is good for a 45-year-old woman with atypical complaints. But when you have a patient that has a very high likelihood of coronary artery disease, in P4, you need to have a lot of disease to get in. You need to go with higher KVs, and that allows you to see through the lumen and have lower or more specificity in the assessment of the disease. Now, this is with normal scanners. Okay? Now, we have 3 sites in P4 with photon counting, and the difference is it's like another world. If you are not following what is happening in the CT field, 2 years ago with the photon counting CT, the resolution doubled. So we went from 0.4 to 0.2 millimeters. And in addition to that, there is a specific way that you can remove the calcium, so calcifications are no longer a problem. I have recently, I'm involved with a team of San Francis in the US, assessing the agreement of photon counting with OCT in terms of vessel size. Unbelievable. So even in the future, we'll be able to size very precisely with photon counting. The calcium will not be a problem. And I think we will be able also to look through stents. So I think that's certainly the future. We're going to wait a little bit. I think we need a couple of years until this become mainstream. But I think that's the future, certainly, of CT-guided PCI, the photon counting approach.
Nick, do you have any comment before we go to Yannis?
Yeah, just make a brief comment. Excellent presentation, Carlos. Obviously, you get so much information from just CT pre and post. My experience has been in modeling CTOs and coronary total inclusions. We use CT a lot for ambiguous proximal caps, and I get exactly the same information that you were talking about. Unfortunately, we don't have photon count in CT, but I've seen images, and 0.2 millimeters is just incredible. I mean, this is better than what most centers have. One other comment I was going to say, when the P4 that's randomized, which is going to be a great information to see non-inferiority or even superiority to IVUS. But sometimes what I like to do is post stenting. I like to look at the edges of the stent, and on IVUS or OCT, if sometimes you miss a dissection edge, by angiography, but you see that on IVUS or OCT, and that makes you change your strategy a little bit. And with your randomization, I guess that's not possible because you can't use the post imaging either. Is that correct?
Yeah, that's correct. So indeed, it's a trial. There is a question. We are trying to be rigorous here from the scientific point of view, and some people say, well, but the trial is biased towards CT because you have all this information that you cannot get from IVUS, and you got the physiology, and then you got the prediction. Yes, that is true, but you also don't get what you're saying. You don't get a very detailed assessment of the edges. So so I think this is where we're testing. I have to say that I'm pretty curious. You said superiority. I think that we're not aiming at superiority of CT at the PCI, but that's going to be P5. In P5, we're going to do superiority of planning with CT versus no planning, because in the meantime, Nick, we kind of understood that there is a big value, as you said, to plan the procedure. It can be a CTO, it can be a lift main, it can be a bifurcation, but if you go in already with a deep understanding of the disease, that changes the procedure from the decision making, also from the technical part.
Thanks, Carlos.
Bimmer, please go ahead and use Yannis. Get started.
Great. Well, I think our next speaker also actually needs no introduction, but I'll try anyway. So Yannis Chertzizidis is a professor of cardiology at the Middle School of Medicine, University of Miami. He is the chairman of the SCAI Bifurcation Club. He's also very active in the European Bifurcation Club, and he will enlighten us on how we can integrate computational models in our practice to improve outcomes with bifurcation PCI within his next talk.
Thank you, Bimmer. Thank you, everybody, esteemed panelists and attendees online, and thank you, Dr. Raab, for this huge initiative here. It's wonderful series of webinars. I think I'm going to say more or less the same thing that Dr. Colette said, but using invasive interventional imaging approaches and a little bit of simulations to show how our PCI will look like if we follow the prediction. These are my disclosures. And the whole idea, agreeably, is to do our very best to improve this problem here. The adverse outcomes associated with PCIs. PCIs help a lot, but also they come with a price of adverse events. And sometimes when it comes to left main, patients with diabetes, it can go up to 30% event rate within 1 or 2 years post-PCI. The best way to improve the outcomes after interventions is to achieve better planning, as Dr. Collet said. And by failing to prepare, we're preparing to fail, as said by Benjamin Franklin. And what is missing essentially in our approach is an individualized integration of anatomy and physiology. And AI here comes to play an important role. It can leverage all this individualized anatomical and biological and physiological data in a very seamless way to help us plan in a time and cost-effective way. With AI, we can achieve automated lumen segmentation of intracoronary imaging or any kind of imaging in real time, at the point of care, ad hoc in the cath lab, co-registration with angiography, because we operate on the angiograms, not on IVUS or OCT consoles or CT scanners. 3D reconstruction, our brain is advanced, and as already mentioned earlier, we are used to operate in 3D, and it's a violation of our skills and abilities, natural abilities, when we're asked to take the 3D into 2D luminograms. FFR, very important to know the significance of the lesion we deal with. Automatic plaque, material segmentation and characterization based on imaging. And of course, simulation to show us how the PCI will look like before it happens. Let me walk you through these concepts. We have developed this stent platform, digital stent platform, which integrates any kind of imaging. It's very versatile, any IVUS, any OCT plus angiography, even non-invasive imaging with CT. It creates digital twins of the heart arteries with the faithful representation, replicas of the lumen, the wall. The biology is there, is integrated by imaging. We integrate into the 3D reconstructed wall the materials of this particular individual, and then we plug everything into the computational simulations where we add patient-specific, very realistic stent designs and balloons, and we come up with planning of procedures. We have tested the feasibility of this approach in a series of patients, and I'm going to show you today a patient-relevant example. This is a 60-year-old woman with ischemic cardiomyopathy, history of stents in the LAD in the past, and circumflex and diagonal, and severe distal left main, angiographically by IVUS, 4.9 square millimeters of distal left main, shown here in the long view. And what we did in that case is we stopped there and we took the artery, this diseased left main, from the body to the computer. You see here the faithful digital twin, the replica of the left main anatomy with the distal LAD, with the LAD stent from the past, the MLA 4.9 at the distal left main. And we went one step further. We integrated realistically in 3D the material distribution of this particular bifurcation using OCT imaging integrated to the angiogram. So fibrosis here, calcium in 3D, as shown already by CT by Dr. Collet. And we went one step even further, and we translated this material distribution into stiffness, because at the end of the day, stents don't care about the material, but they care about the stiffness they are expanding against. And you see here a very comprehensive mapping of the stiffness along the 3D reconstructed by intravascular imaging diseased left main bifurcation. And you see here the correlation of each OCT frame on this stiffness mapping. You see here this particular case, again, distal diseased left main looks stiff. Red means very stiff. On the white side means less stiff. And you see here the flow dynamics, the acceleration of flow through the diseased distal left main, LAD and circumflex. And the beauty is now we allow the AI and simulations to recommend for this particular anatomy what's the best standing strategy, how we predilate this lesion, how we stand, what stand length, size, diameter, one stand technique here, post-dilatation. And this gives us an adequate result. And the precision is very high here because you see that the machine, the AI system recommends a minimal overlap of millimeter with the previous stand and also protrusion of the stand into the aorta by a millimeter. So very high precision coming from integration of existing imaging, which we do every day, but maybe we don't squeeze the juice of this lemon enough. And you see here the distal left main hemodynamics before and after the virtual PCI, where you see restoration of flow in the diseased distal left main to the LAD and adequate flow at the osteo of the circumflex, mitigating essentially the need for a second stand. And again, so far we're all simulation, all digital. And now we take this recommendation into the cath lab. And what I show you today is an offline process, but we are having data and we're working very diligently to make this real time. And I believe we'll have this very soon to have the planning in real time. So here we execute exactly the same plan to the dot, same balloon, same inflation atmospheres, pre-dilatation. Step 2, crossover standing with a 3.5 megatron from the old stents in the LAD all the way to the osteo of the left main with small protrusion into the aorta. And then finally, post-dilatation with a 4.5 balloon at 18 atmospheres as predicted, as recommended by the AI in the simulations. And you see here the baseline before stent. And we see here the all simulation AI guided planned left main PCI with the result angiographically looking great and the almost ×3 increase of the diseased left main from 4.9 to 16.4. You see here also on the long view. And this is also very exciting to see the precision of the AI guided PCI compared to reality. Here is the MSD across the length of the stent. Black is the actual achieved diameter of the implanted stent by IVUS, and red is what the simulation and the AI predicted. And you see here a very high agreement between the prediction, the AI-based simulation, and prediction with the actual reality, which means that in reality, we were able to faithfully execute the predicted plan. So where we head? We're heading in the years, hopefully near future, as we discussed already, invasive or maybe non-invasive imaging looks more powerful with the advancement of technologies lately. Use AI to diagnose obstructive CAD that needs therapy, then use computer vision to devise a patient-specific treatment plan for this particular individual, then plug in the robot to achieve, to deliver this recommended plan using the AI-based diagnosis of CAD coming from non-invasive or invasive imaging. And this way we can achieve consistency versus interoperator variability, which we see a lot. And hopefully with this approach, we can have better guidance to the operators who will still be there, guards of the operation, but being more focused and more prepared, more informed for their procedures, improve cath lab efficiency, patient satisfaction, healthcare costs, and hopefully the holy grail of what we do is improvement of clinical outcomes. And that's the planning part of computer simulation AI. Also, it can play an important role in regulatory approval of devices. We have different techniques or different devices. We can have the so-called in silico virtual clinical trials, where we use heterogeneous, very diverse patient data, not actual patients, and extract simulation outcomes, endpoints, which are highly predictive of actual clinical outcomes. For example, stent expansion is very highly predictive of the stent stenosis. And this approach can guide us towards very focused, very informed actual trials with the real patients, real outcomes to inform academia, NIH, industry, and so on the devices we have to help essentially the process to advance new scientific knowledge in a very time and cost-effective way. And that's something that FDA prioritizes nowadays, because this approach, the in silico clinical trials, facilitating actual clinical trials, can help us with impactful scientific knowledge in a very time and cost-effective way. We learn more in faster and cheaper way. And then third application of the simulations, on top of planning of procedures, on top of virtual trials to accelerate the regulatory approval of devices. We also have these tools, these techniques to help us with education and training, to help our trainees learn greater, faster, better using simulations and extended reality. You see here, this is our fellows. Before they go to the cath lab, they wear the headsets, spend like an hour in the virtual replica of our cath lab. They can play around with the eye to see how in each projection the coronaries look like. No X-ray, no contrast, seeing is believing. Same here from our advanced fellows, from the outside, from the inside. They can grab the stent, like being totally immersed in a site to see how a provisional stent looks like from the inside, from the outside, how the provisional technique interacts with the side branch. For more advanced techniques here, you see this decay culotte. You see, in this case, this is patient-specific. There's a realistic lumen and wall. The stent design and material is realistic. You see here the first stent, pot now, and now you see the second stent coming in, and see how it interacts with the other stent. Indispensable cognitive experience that helps us understand things better and remove the old school teaching method, which is by trial and error or on our poor patients. So we essentially moved to a totally digital era in cardiovascular intervention in general in medicine, where AI, simulations, virtual reality will play central role in, first of all, democratization of expertise. Imagine what we can do with CT or invasive imaging, it doesn't matter. But what matters is that in India, in Greece, in Latin America, across the globe, we can have access to the latest for the expertise versus relying on specific experts in specific geographical regions of the world. We can use all these technologies to plan our procedures ahead, and by that we can improve our outcomes. We can use these technologies to develop faster and more efficiently our devices, virtual clinical trials for accelerated pathway through FDA, and of course, education and training to help our trainees learn greater, faster, and better. The future is exciting and it's happening. We had the honor to put together a compilation of many papers, review and original papers, in this SCAI special issue that just came out a few days ago. I had the honor to co-edit this with Dr. Edelman from MIT. Take a look. I think it's worth it to read these papers, these articles. A big thank you to the members, my group at the Center for Digital Cardiovascular Innovation at the University of Miami, engineers, MDs who work hard in these concepts. Of course, a big thank you to the funding sources from the NIH, from industry and philanthropy, and a big thank you to all of you for your attention.
Thank you.
Thank you very much. That was an amazing presentation. If I could just ask one question, I think you actually have the potential to lay another layer on top of what Carlos Collet just presented in his previous presentation, because not only maybe will we be able to predict what is the FFR after the procedure, but having these newer computational fluid dynamic type of analyses could also help to perhaps guide us which type of bifurcation technique would be optimal to get optimal flow characteristics after procedure. Obviously, doing this offline would be easy. I know that computational fluid dynamics takes a lot of computational power as well, so you need a machine to run for a couple of hours to get these models right. But if you're able to do this perhaps with some advanced AI technology to get it integrated into the cath lab, that would be an amazing step to maybe even help you while you're doing these procedures, and maybe switch tack if you think that a different approach may have some benefits. So could you maybe comment on the developments that are ongoing in us using these techniques real time in the cath lab, maybe in the near future?
Without question, Bimer, interventional cardiologists would feel very unhappy if you had to take a patient off the table, make a planning, and bring the patient back. This would be totally unattractive. And count my words, what we do at this point and where we're heading is a real-time anatomy, physiology, biology, and planning of procedures at the point of care, ad hoc in the cath lab. Once we hit the IVUS pullback, the OCT pullback, within a matter of 1 or 2 minutes to have the whole operation planned again in real time.
So
That sure sounds exciting.
So John, you are a budding imager, or intracoronary imager. So what are your thoughts?
I mean, I think that's fantastic. I think one of the things that I've loved about OCT is the prescriptive nature of MLD Max and walking in with the plan. So anything, and to your point, the efficiency of it, right? You're not guessing, you're not trying different things, you're imaging and working through an algorithm. So I think if the AI has the ability to give you that in 1 or 2 minutes, it's a game changer. It's really impressive work and a really nice presentation. Thank you.
So for all of you, this is available on SCAI-TV to look at. One thing, so Yanis, for your case that you showed, why didn't you do a follow-up imaging with OCT rather than IVUS? Because we started with an OCT-guided, 3-dimensional acquisition. So why did you not end with the OCT follow-up in that case that you showed?
It's a matter of preference. We started with OCT. We ended up with IVUS. I don't think that HD IVUS is also very high resolution. We could do OCT. We just elected to use
So you could do the pre-planning with HD IVUS as well. Is that correct? I mean,
of course, you can do pre-IVUS, post-IVUS. You can do pre-OCT, post-OCT. You can combine them. You can do CT. You can do CT. Again, we have plenty of time with CT to do the 3D, essentially what Carlos showed. And then on top of this, do the simulation, show how this provisional standing in this trifurcation would look like before you actually do it. And this will give you important information to get a sense, a cognitive understanding of how the stent would interact with the side branches, how they would look like. Again, we talk about patient-specific models which integrate anatomy, physiology, and biology.
So there's a question for Carlos. Carlos, what about aortic ostial lesion in your algorithm, or a 010 lesion in your algorithm?
So aortic lesions for me is one of these lesions subset that you don't want to do anymore without CTs once you get used to that. And the reason is you can really understand what is the precise angle to really see the ostium perpendicularly. There's a paper published this month in Circulation Intervention showing basically CT guidance for ostial PCI, with the endpoint is IVUS geographical maze, angio versus CT. And you see that when you use CT, you land where you wanted to land, because you were guided which projection was the best one to basically show you what you wanted to see. So I'll tell you a personal comment. When I go to the lab today and it's an ostial lesion, and I fully agree with you, Yanis, what you said, that you don't want to take the patient off the table and then bring it back. But there are a couple of scenarios where when you don't have a CT and you don't know exactly where you are, having this information coming from CT, it really makes the procedure safer for the patient. And one of these subsets is ostial disease. So Tamer, I think ostial disease, bifurcation lesions, CTO are sweet spots for CT planning.
Well, we're coming to the end, but we have to get rid of SPECT imaging altogether. And I think that is a big call in the US. We still have problems with insurance, as I said, but I think this is the way to go, even photon CT comes along. And I think there's a lot for the younger generation interventional cardio. Hopefully, you can integrate this all into your practice. How do you get away from the radiology turf, Carlos? And radiology trying to be involved in this, and we are interventionists trying to take this away from them. How did you manage that? I mean, this is a big issue for us.
Yeah, that's a good question. So I think with our radiologists, we work together. So basically, we look at the tough cases. We do that once or two times a week. We meet and we see the cases. And what we have seen is that the collaboration has really increased, and we try to teach them PCI. For them to report what we wanted to learn, but at some point they said, guys, we will never learn what is relevant for PCI, so it's better that you get involved, and then we basically share the program. So that's the way that things evolve from our side.
Thank you very much, Bimer. Aisha, any final words?
I also think with the CT, like the way in Europe, we have these heart teams where we work very closely with our radiologists as well. When we do our TAVI team, the TAVR teams, the radiologist is also in the room. Well, I know in the US there's a lot of planning being done by the cardiologists themselves or by the companies, for example. So really, the way to be able to get CT to the next level is also to collaborate with your radiologist on the next level. And I think in Europe we've been doing that, particularly in the TAVR space, for a long time. And the coronary space, now that it's evolving and now that the software is there and the AI integration is there, we're seeing great benefit from that, because it's just that much easier to extend it into the coronary field, that collaboration that was already there.
Aisha?
Thanks. I think two incredible presentations showing what a lot of tools we have out there to improve outcomes. And I suppose the only caveat, if at all, would be integrating this into training, because already things like intravascular ultrasound, most are undertrained. It's not incorporated in many programs of mandatory fellowship training across the globe. So integrating all of this into training would probably be the next challenge. But nevertheless, it's two incredible talks. Thank you.
Thank you very much. The time has come for us to stop. And thank you, Laura, for being involved today. And we hope to see you all soon. Thank you very much. Excellent presentation. Thank you.